Welcome everyone to this new episode of the series of webinars She Care What Really Matters that Wellspect and ISCoS are collaborating with. My name is Francesca Paola Polli. I am the enterology product manager for Wellspect in Italy, and I am very honored to be your host for the webinar today. It's really a great privilege for Wellspect to collaborate with ISCoS and contribute to its podcast and webinar series. Our common goals is to engage conversation, share narratives, and of course offer insight into bladder and bowel management, integral and crucial aspect of she care. This episode in particular will spotlight the often overlooked dimension of the sacral area, the sexual aspect and activities for people with spinal cord injuries. Our webinar today is entitled Exploring Sexual Dysfunction in She Individuals and will delve into this crucial consideration. Please join me in welcoming our very estimated guest, Dr. Marcalee Alexander. Welcome, Dr. Alexander. And Dr. Gianluca Sampogna. Welcome, Dr. Sampogna.
Thanks.
Dr. Marcalee Alexander is a specialist in physical medicine and rehabilitation. Throughout this very long career, she has focused on her work on quality of life of treatment of sexual dysfunction after spinal cord injury, conducting extensive research and having written multiple books and videos in this field. Very recently, her focus is on impact of climate changes on persons with disabilities. She founded and is president of Sustain Our Abilities, an NGO that focuses on education regarding climate changes, disability, and health. And she is also editor-in-chief of the Journal of Climate Change and Health. She also is involved in a walk from Canada to Key West called the Green Route, aiding healthy adaptation and mitigation to bring attention to the need for a healthy environment. Very welcome, and I'm very honored to be your host today, Dr. Alexander.
Thank you.
Dr. Gianluca Sampogna is a urologic surgeon working in the spinal unit of Guarda Hospital in Milan, where he helps people with spinal cord injury to rebuild and achieve an active and satisfactory sexual life through sexual counseling, sex toys, prescription of medical therapies and surgery, such as penile prosthesis. Over the years, he has built a successful collaboration with Dr. Marcalee Alexander. In fact, he translated the Italian version of Sustainable Sexuality, a guide for an active sexual life after spinal cord injury. A widespread pamphlet for patients and their partners. And together they wrote a chapter for health professionals entitled Telerehabilitation for Treatment of Sexual Concerns. Very welcome, Dr. Sampogna. Our guests, as you can imagine, are a very dynamic duo, full of enthusiasm and passion for their job. Also because the matter, it helps, with different backgrounds, which complete each other as always happens. The woman and the man, different generation and countries, a clinician and a surgeon. So we can start in a very dynamic dialogue with our experts as they provide comprehensive insight into sexual activities for individuals with spinal cord injuries. And here, the first question. How can spinal cord injury affect sexual life? Would you start to answer, Dr. Alexander?
Sure. Well, spinal cord injuries certainly impact people's sexuality and their sexual function. And we know that after spinal cord injury, people's bodies change, right? There's a decrease in sexual activity, there's a decrease in interest, and that's pretty general. And that's what happens after spinal cord injury, And because of this, people have to reacquaint themselves with their sexuality. But I think the other thing that is really important to realize with spinal cord injury is that where the injury is affects how the person's sexual function is changed. So we have to break this down, and it's a little complicated, but I'll go through it as simple as possible. Basically, when we are sexually aroused, there's two ways that this can happen. You get turned on, right? You get turned on in your brain when you see someone or hear something that makes you sexually excited. You can also get turned on, though, in the genitals when you get touched or you rub up against something, you might get excited in the genitals. So in able-bodied people, it's an interplay. There's arousal in the brain, arousal in the genitals, and they work together so that an able-bodied person doesn't get excited when it's not the right time. They get excited when it's the right time, when it's appropriate. Now, when you have a spinal cord injury, though, because of the injury, the different pathways can be impacted. So if an injury, and if we talk about the spinal cord, we go from cervical, thoracic, lumbar, sacral. And if the injury is higher up, if it's cervical or thoracic, then the brain going down to the genitals, the impulse can't go through. The impulses for sexual function are actually in the sacral area and the lumbar area. So if it's above, it's going from the brain down. If there's a complete spinal cord injury, the person can't get aroused in the genitals from thinking about something. On the other hand, if the injury is below, the person may not be able to get aroused from the reflex level. Now, that's with complete injuries, but when injuries are incomplete, different things can happen. And what we found is that when someone has an incomplete injury, the amount of sensation between the belly button and where the pockets are, if your hands are in pockets, the more sensation in that area, the more chance there is that you can get genital arousal from a brain thought, from thinking. And then if there's no reflexes in the sacral area, then the reflex arousal will be decreased. One thing I need to say, though, and Dr. Sampogna, I'm sure, will chime in here in 1 second. So when we talk about arousal in the genitals, it's basically increased blood flow. And so in men, and I'm very simple here, so you may want to be a little bit more technical, but in men, that increased blood flow leads to erection, and in women, it leads to lubrication. So the more arousal, more blood flow in the genitals, the more lubrication or erection. And there's two kinds, depending on where the spinal cord injury is, one or the other, and sometimes both may be affected. And that's where Dr. Sampogna has to come in and provide his treatments for the men with spinal cord injury, especially for erectile dysfunction. There's also the question of orgasm, but let's take that one a little later.
Okay, of course. We will have a very interesting conversation about this. And what's your opinion, Dr. Sampogna?
So I want to say that I think that there aren't many events in life that can affect your sexual life more than a spinal cord injury. The first thing that you have to tell your patient is that you may feel unattractive. Of course, this is possible, but they should find the courage to consider themselves as unique and irreplaceable. And I think that this is the most difficult step in the beginning. Later, there are many problems to assess, for example, spasticity, pain, problems regarding lubrication, erectile dysfunction, and so on. Autonomic dysreflexia, of course. But we have many weapons in our armamentarium to help our patients. we have to tell all these things because we have to inform them. But I think that the most important thing to do from the very beginning is to say, okay, sexual life is impaired in a significant way after the spinal cord injury, but we have many weapons for you. So follow us and we will tell you how to solve the many problems that you will encounter.
The only thing I would say, Dr. Sampogna, is I wouldn't call them weapons. I would call them toys for you.
Because
we have to make sure sex is fun.
Yeah.
because you're a woman, Dr. Alexander.
You're right. You have many solutions. You're right, and of course, toys.
Toys. And so, what are the most common misconceptions around this theme in people with spinal cord injuries? For example, they say that even if they have no sensitive or sensory loss, they can have, as you mentioned it before, Dr. Alexander, they can have always a kind of pleasure in having sexual activities, correct? So what you can say to this patient in this area?
Well, one of the things that I've spent a lot of time on is looking at the issue of orgasm and spinal cord injury. And I have to say, when I was very junior in my career, I really couldn't figure it out and didn't think that people with spinal cord injuries, at least from what I learned, would be able to have orgasms. And then when I started doing research, we looked at people in a laboratory where they masturbated, they stimulated themselves to have pleasure or have an orgasm. And what we found was that the only people with spinal cord injuries that weren't able to have an orgasm, or some people may call it a climax, were people that had very low levels of spinal cord injuries, the sacral injuries, and the people that had complete sacral injuries. So everybody else could come up to a point where they would have some type of climax. Now, not everybody, most of everybody else. But then as I got older and experienced life and, saw more and more patients, more things, what came to my mind was when we talk about spinal cord injury, a lot of times we just talk about the pure people that are young and have no other medical problems except for spinal cord injury. There's not a lot of people like that. Most of us have other things going on. We're only 25 years old for so long, and then we start getting older. We have children, we have high blood pressure, we get heavier, and doctors start giving us medicine. And the issue is that I really see a lot is that when we work in spinal cord injury, we have to realize that many medications that people are on can work against their sexual function. So from my standpoint, I think it's really important for physicians and nurses to emphasize the positive, that there's a lot of possibilities for people with spinal cord injuries. It just takes practice. It takes a lot longer than before injury. And you've got to, as Gianluca was saying, you've got to really think about, yes, it can be fun. Yes, there's a lot we can do for you and try. But what I do see is that with good information, with good education, people can be sexually satisfied. And I think sex is good for people. There's a lot of information that shows that ejaculations or orgasms decreases spasms. So that's what we want to do. In some ways, we have to be like cheerleaders.
Okay, thank you, Dr. Alexander. What about what you could add, Dr. Sampogna, to these ideas, to this experience?
Yeah, The idea of getting an orgasm without sensitivity at the level of the genitals, I think this is the most common misconception in spinal cord injury. I usually tell my patient about this comparison. Think about the movie The Intouchables. The main character was tetraplegic and he was able to find pleasure by stimulating the earlobes. So the patient is able to get non-genital orgasm by stimulating other parts of the body, for example, the lips, the nipples, the neck, and so on. But it may take a lot of time. So you have to encourage your patient not to stop, but to carry on with stimulating these areas. And I usually tell my patient about the fact that during adolescence, they took a lot of time to know what it worked for them and what didn't work for them. So now it may take a lot of time as well to realize what it works for you and what it doesn't work for you. But the travel deserves it. So you have to start and you have to go on with the journey.
Of course.
The other thing I would say is that when you have orgasms, for able-bodied people, the sensation you're feeling is inside. It's not outside. It's not, it's not a sensation you can recreate by just touching something one time. So we have to realize that when you have a spinal cord injury, you really have damage to your somatic nervous system as opposed to your autonomic. We don't, your heart still beats, you still breathe, all these other things still happen. So orgasms are actually, in my mind, a reflex in the autonomic nervous system, and that part of the nervous system is still intact. It's like, how do people with spinal cord injuries have pain if they can't feel, but they still can have pain? So the same thing, they can't feel on the skin, but they can still feel sensation inside.
Okay, thank you, Dr. Alexander. And when or how you can start to talk about this with the patient? I mean, you talk directly to patient alone or with the partner or with the peer. So can you describe when you start to talk that a sexual life is possible after a spinal cord injuries? Please, Dr. Sampogna, could you start you?
Yes, of course. By our spinal unit, we usually talk about sex from the very beginning, but in general. In general, we tell the effects of spinal cord injury on sexual life, but we usually get more in depth when the patient starts to go back home during the weekends, during his or her rehabilitation, because in Italy the hospital stay for the rehabilitation after the injury is really very long. It may last up to 1 year, and during the last part of the rehabilitation we help our patient to go back home and start again to live their lives. And during this phase, usually they come back to us and they want more knowledge. They want more information about how to start an active and satisfactory sexual life. Usually, the first dialogues, the first sexual counseling sessions are performed alone with the patient. Later, we can perform these sessions with the partners, and there is an interesting difference. There's an interesting difference between men and women, because usually women ask for their partners during the very first sessions. So probably they want to get more information about having a new sexual life together earlier than men. While men, during the first phases, usually they want to perform autoerotism alone, just to get more in depth with their exploration. As for dialogue with the peers, usually patients ask for them if they have to undergo penile prosthesis surgery, for example, because it is an irreversible procedure, and in these cases, they want to listen to the information from other patients who underwent this surgery before.
Thank you, Dr. Sampogna. And what's your experience, Dr. Alexander? What would you add?
You know, my first comment has to be, I want to move to Italy. It's amazing. It is, you know, in the United States, people have spinal cord injuries and they get sent home, even with tetraplegia, they can get sent home in a month, 1 month compared to 1 year. So just imagine the difference in what people can learn in rehabilitation. When we talk about sexuality, I tend to follow the same approach with Dr. Sampogna. Give people some general information in the beginning, make sure they know there's a lot of good information out there, a lot of solutions, and I really do suggest with everyone that they explore. We recommend autoeroticism or masturbation, whatever you want to call it. And I explain you've got to learn how your body works. And it's easier to do that by yourself, because if they're with their partner, then they're worried about their partner and whether their partner's feeling good and what their partner thinks their body looks like. So I do encourage people to explore their bodies. Definitely encourage women to use vibrators, etc. And then as time goes on, give people more information. It's really true that people don't like soak up the information in the beginning, because I can't tell you how many people I spoke to about sex when they were early on, and yet they don't realize it. And so it needs to be something that is brought up when people come back in as outpatients and when things go on, and say, well, how are things? You know, this is still something that's a possibility, so that they feel comfortable opening up to you.
Okay, thank you. And you just talked about the difference between men and women, for example, but what about the other gender, we can say so, or gender minorities? How can they approach? How can a doctor or a healthcare professional can approach these people? Please, would you continue, Dr. Alexander?
Sure. I mean, I think, you know, sexuality is so much broader and so much more open than when I started my career. And certainly we know that, you know, a large percentage of the population would rather have same-sex relations or relations with people of both sexes. And, you know, I think you just talk about it as you regularly do with anyone. Many women are married to women, many men are married to men. And so the issues are not much dissimilar if you are gay or if you're straight, or, you know, no matter what your sexual orientation is, the issues are generally similar. So, you know, it's just part of life.
Yes, I agree. The life is the life. So, and the sex is the sex. I agree. And what about your Italian experience, Dr. Sampogna?
Yeah, actually, we don't have a lot of experience in this field. In 2021, there was an interesting commentary in the Journal of Spinal Cord Medicine regarding the request for more information about sexual and gender minorities. I think that we have learned a lot of things from our patients. For example, when we talk about sex positions, I've learned a lot from my patients, and I would like to learn a lot of information from other sexual and gender minorities, but I think that in this period we need to get more information from our patients, to publish them in order to share all our knowledge among clinicians all over the world, in order to increase our knowledge in a short time, because we must get and release information also in this field. So this is a very interesting research topic, I think.
I would also want to add that a couple years ago, I did a video series called Everlasting Love. And it was funded by the Paralyzed Veterans of America. And actually, Dr. Sampogna was on for a couple of episodes. And it is available now. It's not on YouTube. What's the Vimeo? It's available on Vimeo. It's free. And there's 40 episodes. But there is an episode where we had a number of people that were same-sex. We had a special episode on LGBT issues, and people can watch that episode and have people talking about the issue and how it impacts them.
Thank you, both of you. And before to go inside some practical aspect, what about bladder and bowel management for to have a good sexual activity in spinal cord injury? How can you can suggest to manage it? How is important, or if it's important to manage also bladder and bowel management to have a good sexual activity? Would you start, Dr. Sampogna?
Yes. So this is really very important. I always tell my patients that before thinking about an active sexual life, they have to get an appropriate bladder and bowel management for many reasons. First of all, you have to think about the fact that the mind and the brain work in tandem. It means that if the patient experiences an episode of urinary and or fecal incontinence, the patient should stop going on with the exploration of the sexual life. And the mind problem could become predominantly. So in these cases, we have to solve the mind problem and later go on with the exploration of the organic functions. So I think that in these cases, first of all, we have to give general suggestions, for example, to empty the bladder before having sex, even if a full bladder may help to get an erection. But I think that a urinary incontinence episode may be more detrimental for the patient. The same thing for the bowel. An appropriate bowel management is always essential in order to reduce these fecal incontinence episodes. And if you think about fertility issues, if a male patient has many infections, and these infections are usually due to an inappropriate bladder and bowel management, the testicular parenchyma may suffer from this inappropriate management. So the opportunity to become father in the next year will decrease. So we have to tell all these things to our patients in order to get an appropriate bladder and bowel management also for sexuality from the very beginning.
Thank you, Dr. Sampogna. What about your suggestion, Dr. Alexander, or your experience about in this field?
Well, I mean, I agree with Dr. Sampogna. Most people don't want to have bladder or bowel incontinence when they're sexually active. Now, there still is a percentage of the population that may use a Foley catheter and keep that in during sex. That is something that people still do. And there's still people that have suprapubic catheters, and they might have sex with, while those are intact. But in general, most people don't want to have accidents when they're sexually active. So we usually recommend that people do their bowel care or they catheterize themselves before they're sexually active.
Okay, thank you for sharing. And so, if what about, for example, now the first practical steps? You mentioned something before, when people start to talk about the possibility to have sex, and what are your suggestions? What are your practical tips and tricks that you can share with our healthcare professionals that listen to this webinar today? Please, would you start, Dr. Alexander?
Sure. So I think when you're going to speak about sex with someone, it's really important to think about that person and who they are. And then this is for more one-on-one conversations as opposed to speaking to a group of people. But if you're speaking with someone about sex, you've got to think about before their injury. How was their sex life before their injury? Were they interested in sex before? Are they a young person that's out dating? Are they a married person that just had children? Is it an elderly person? So you need to, say, so we need to talk about having fun and pleasure. That's still possible after spinal cord injury. Is that something you were interested in before your injury? And, that's kind of a little icebreaker there. Like, what were you doing before injury? And have you thought about it since your injury? And, kind of get into the context of the individual. Now, when you think about it, though, you've got to think about age. You've got to think about their pre-injury functions. So you've also got to think about their relationship status, their experience, their sexual orientation, their gender orientation. So you've got to put all that into it. And then you've also got to think about something else. You've got to think about cultural and religious issues. You certainly cannot talk about sex the same way with someone from a very conservative society as someone from a very liberal society. So when you put all that together, then you can start talking about sex. And you want to do it in verbiage that you think the person's going to understand. So that's where it gets a little bit more tricky. But, I would say, this is an important part of life for most people. What do you think about it? Is it important for you? I'd like to give you some basic information and encourage you to explore what works, what doesn't work for you. And once you learn, I can help you adjust your medications. I can also help you speak with your partner and kind of take it that way with the person. Meeting them where they are and saying, this is a journey you can go through with them, with or without their partner, as they see fit.
Thank you, Dr. Alexander. And what about the Italian aspect? It's conservative or liberal, Dr. Sampogna?
It depends. It depends. It depends. Yes, I think that in the last years we are facing with a significant change. The first practical steps that I usually suggest to my patients are lubrication. Lube is never enough. Other practical steps regard the bladder. So empty the bladder, even if the erection is better with the full bladder, but I think that you have to reduce the incidence of urinary incontinence episodes. Another suggestion is to use cushions. Of course, cushions are essential to reduce the pressure at the level of the bones, but also to expose some areas. For example, you have to think that in some cases there is an hypertonus at the level of the adductor muscles, and the cushions may help you in these cases. Other practical steps regard the importance of checking your skin after having sex, because you have to realize whether some pressure source appear after the sexual act, and in these cases you have to start with the treatment as soon as possible. Other practical steps, maybe sex in the morning. Sex in the morning is easier because the muscle fatigue is lower, of course. And other practical steps regards the importance of having sex with an empty stomach, especially in men when they take some drugs, for example, phosphodiesterase type 5 inhibitors. Of course, these practical steps are small suggestions, but all together they may help our patient to have an active and satisfactory sexual life. And I think that they could represent a significant change.
Oh, I can imagine. I can imagine. And in this suggestion, sometimes you also suggest the sex toys, Dr. Sampogna.
Of course, sex toys are an essential part of our sexual counseling. Actually, to tell you the truth, I have learned about the importance of sex toys by my mentor, Dr. Marcalee Alexander. And in our spinal unit, now we are able to give interesting suggestions about sex toys and about their adaptation. Because think about a tetraplegic patient. In some cases, he or she is not able to use the sex toys, but we have the possibility to interact with some occupational therapists working in our spinal unit, and we are able to adapt them. So also in this field, it is essential to collaborate with other healthcare professionals in order to get the patient-tailored solution. And I think that it is easier to find some collaborators in this field because it's a new field, is a new research topic, and I always suggest my colleagues all over Italy to start with this research.
As you can imagine, this question was very easy for me because I've read your booklet, so I know that Dr. Alexander suggested that and helps you in this sex toys area. So would you add something else, Dr. Alexander?
Well, I think that yeah, absolutely, and I think that the point that Dr. Sampogna made about people not being able to use these toys on their own is really important. I think that having a therapist that's interested is important. And people sometimes want you to say, oh, use this, use this. I tend to go away from that. I tend to avoid that because part of it is them exploring on their own and seeing what works. And there are such a variety of these toys out there, right? There's if you look up vibrators on the internet, you'll find 456 pages just on Amazon of different types of vibrators. So it may be toys, it may be lubrication, lubrication that tastes good, lubrication that, gives a little tingling or warms up. So it's a matter of really, letting people use their creativity. It may be that they want to use different types of clothing, right? They may want to do different things. And also, what's nice now is there's so many different types of bedding available, right? You can get, I don't know about in Italy now, but in the United States, it seems that, like furry comforters for the beds are very popular and silky comforters. So all of these things that are pleasurable for people, and they may be pleasurable for able-bodied, but also pleasurable for people with spinal cord injuries with partial sensation. It may feel even better for them. So I think these are all really points to bring up. But I do also want to bring up something else as we're talking about this, because I think that this is where we have to start thinking about partners. And partners need to be brought into these conversations. And I will say that one of the toughest things I think there is for physicians and counselors working in sexuality and spinal cord injury is that many times partners don't want to have sex with their spinal cord injured significant other. And so I think this is something we have to be honest and open about and talk to people about. So I just think that's another important thing, and making sure that, when we bring in the toys, bring in the partner too. Because this is most people like to do this in a couples way, and the partner is generally an important part of that.
Again, I can imagine that it's important to dialogue also with the other part of a sexual life, if there is. So, yes. And now I would like to ask you something about the different between women and men. So some practical suggestion to help sexuality in women, and something to suggest for men.
We have many solutions to help our men with spinal cord injury. I think that, as we have previously said, we encourage their exploration autonomously. So it means that autoeroticism is the first thing that we say, just to realize whether the sensory and motor responses are after the spinal cord injury. So this is very important. I think that there is a big problem all over the world to start directly with medicine and therapies, while it is more important to stay calm and to realize how the patient works after the spinal cord injury. And I think that another suggestion for a clinician is to think outside of the box. So you don't have to go directly with a practical solution, but you have to realize how you can help your patient without giving medical treatment. After that, in some cases, it is really very difficult to get an appropriate erectile function to achieve a sexual intercourse. So you can give a solution. Usually we start with phosphodiesterase type 5 inhibitors. We have different kinds of principles. They work in different manners. So you have to realize whether your patient is going to use it. Because, for example, we can give some drugs on demand. In some cases, we can give it continuously. For example, every 48 hours. As for tadalafil, 20 milligram every 40 hours is really very common by our center because we associated it with the vacuum erection device for 5-10 minutes per day in order to help with the sexual rehabilitation, in the sense that we can help the trophism of the penis in this way. And I think it is very important to stress out as concept. Penis is like a sort of muscle, so you have to exercise it because after spinal cord injury there is a significant damage and also the dimensions of the penis may be reduced. So we have to start as soon as possible, of course, because during acute rehabilitation there are many other problems, but we have to start with sexual rehabilitation. In case these solutions are not enough, we can suggest the injections of some drugs. Okay, for example, aprocodil. In these cases, you have to pay attention for the risk of priapism. So the patient should be informed that the erection may not resolve in inappropriate time. So it may last for many hours. Another solution is represented by penile prosthesis surgery. Penile prosthesis surgery is suggested just in few cases because it is an irreversible solution, but it is one of my favorite surgeries, probably my favorite one, because when it is appropriately indicated, it may solve the sexual life of our patients because they're able to get an active and rewarding sexual life. So usually the patients are really very satisfied with this solution. It works in this way. We can place 2 cylinders in the corpora cavernosa. These 2 cylinders are connected with a reservoir usually placed in the abdomen retropubically, and we can move the saline inside the system by a pump placed at the level of the scrotum between the testes. It works in this way. By activating the pump, the patient is able to move the saline from the reservoir in the abdomen to the cylinders. In this way, the patient is able to have a sexual intercourse. At the end, he can press a button over the pump and the saline goes from the cylinder to the reservoir. This is a special type of penile prosthesis, which is called inflatable penile prosthesis. We also have semi-rigid penile prosthesis, which we usually use in case our patients are not able to maintain, for example, a urinary condom. And in this case, we have to increase the penile girth. These solutions may be associated with some complications, for example, erosion, intrusions, infection. So we usually suggest this solution as the last option, and only in case there is inappropriate bladder and bowel management to reduce the previously described risk. So these are the solutions just for the erectile function. We have, of course, other solutions for the ejaculation and so on, but I think that we can discuss it later. So I give the opportunity to Dr. Marcalee Alexander to answer.
I have to just say this. The first time I saw a penile prosthesis surgery was 1982. It was like so many years ago. Penile prostheses have been around for, you know, and that was before we had Viagra, before we had pumps. That was when people did something called stuffing, where they just stuffed the penis in the vagina. That was the way that erectile dysfunction was treated. So we've made tremendous gains in treating erectile dysfunction. On the other hand, with women, we haven't really come up with so many new things. There are a couple pills that are used for improving arousal. I mean, the issue becomes desire and arousal in women. And the first issue is desire, right? A lot of times women's desire goes down after menopause, when they have kids, and these times correlate with decreases of testosterone in the body. So that's something we have to think about. And this is not something that is, these are off-label issues here that I'm talking about more, but that is something you think about with women is what decreases desire, right? So if you're going to be sexually active, you have to want to have sex. You have to want to have it. And then when you're having sex, it needs to make you aroused. So you want to keep doing it, right? So with the issue of desire, one of the other things we think about with women, since we don't have treatments like we have for men, we need to think about what else aside from the spinal cord injury can be causing problems. And it's different in different countries, but in the US, at least in my experiences, many people get antidepressants because everybody's depressed, right? We're all sad. So we all get antidepressants now. And the antidepressants decrease desire. So as we talked about the issue of just giving people medications with spinal cord injuries, the way I would approach this with women is not just giving them new medications, because medications don't really exist, but looking at their medications and adjusting what they're taking so they're taking the medications that are the least have the least negative consequences. So with medications, with antidepressants, we would try to give them Wellbutrin, or bupropion, which has less negative side effects in terms of sexual function. That may be one thing we do. If the woman is amenable and they are in a situation where they're on, for instance, if you take narcotics will decrease your sex drive. So we may say, well, can we get you down on the narcotics? Narcotics will also decrease testosterone levels. So that may be something in a woman where we say, oh, maybe some testosterone would be beneficial. So what we do is we really look at what is negative in your sex life, what is causing problems. And there's a couple other drugs that we give people with spinal cord injuries that commonly cause sexual dysfunction. And that's baclofen, which we give for spasms, can cause problems. And then gabapentin and pregabalin. These drugs can cause sexual dysfunction too. So we kind of look at what drugs can cause sexual dysfunction and try to decrease those so that there can be more interest. Finally, with women, women like to cuddle, right? Women like to be loved. They like romance and everything. But I think these days, women also want to have climaxes. They also want to have orgasms. And so I do encourage people to use vibrators. I encourage the women to masturbate. And one thing I will say is that we did find when we did research that it took women with spinal cord injuries a lot more time to have orgasms. So I tell them, this might take longer than before. And I think that's an important thing to also say to them. So, I kind of take the wholehearted approach in terms of this when I deal with women.
I just want to add one thing. I think it is
Of
interesting in
course.
this case because Dr. Marcalee stressed the importance of self-exploration during masturbation, and I had a patient who realized during masturbation that he was able to have pleasure by stimulating just the left part of the scrotum, and he tells his partners to stimulate that part because he's able to get an appropriate erection for sexual intercourse just stimulating the left part of the scrotum. So this is very important because probably in this patient, other clinicians should start with drugs, medicines, and so on without a solution, while it is really very easy in this case to get an appropriate response by just simulating the right part. But this was possible just with the self-exploration. Otherwise, it could be impossible to realize what it works for him.
Absolutely. And that stresses another thing, and that's communication. He's got to tell his partner. And people with spinal cord injuries really have to learn to be super communicators.
Probably in the past it was more difficult, but I'm finding more and more young people who love to interact with their partners and are really very sincere with them, and they explain everything.
So the importance of dialogue in a couple, as usual, supported by suggestion of doctors. That's the meaning. What I bring with me regarding this series of questions. Since we are close to the time that we have for today, I would like to ask you what you really learned from your patients, from your experience about the sexual activity. So what the patient teach to you, I can say. You can start, Dr. Alexander.
Always give me the hard questions. Now, I think it's really the importance of communication. Sex is about, sex feels good, right? There's no doubt that that's an important part of sex. But the other real important part of sex is being able to communicate with people. It's really, like the ultimate friendship in some ways, because what in my theory of it, when people are having orgasms, they are shutting down their brain and they are opening up. And if they're having orgasms with a partner, they are letting that partner know that they feel totally comfortable with them and all their defenses are down. And so they trust the person. And so they're not only sharing something that's very pleasurable, they're sharing something that's very risky. And so I think what I learned from people with spinal cord injuries is that when they are able to share that way, they can even have better sex after injury than before.
Thank you, Dr. Alexander. And what about you, Dr. Sampogna?
I have learned a lot from my patients. Yeah, this is very, very important to stress out this thing, because I think that most things we usually tell our patients about the possibilities to get an orgasm and to have an active sexual life, actually we learned these things from them. So we are just spreading the knowledge that we get from our patient to other new patients, I think. And as for other solutions, I think that we are just in the beginning and we have to get more experience. So we can get more experience only if we have the possibility to interact with open-minded patients who are prone to tell us many things that they experienced in their life and that work in the appropriate way for them.
And thank you. And so, what is your hope for the future, Dr. Sampogna? What can be, what will be, or what you expect? What are your best expectation for the future in this field?
Yeah. I think that there are so many patients all over the world who are not able to get an appropriate access to the cures for them. And I would like that all people with spinal cord injury find the courage to seek for help and find the possibility to have a doctor, a clinician, an healthcare professional who is able to guide them through the exploration of their new sexual life. So this is my hope for the future. I think that as Marcalee said at the beginning, we have many choices for them, but sometimes we are not able to use them because the patient don't ask help, and they are not interested in finding a solution because they say, okay, now this time for sexual life has finished. So I think that we should change this mind.
Of course, I agree with you. What about you, Dr. Alexander? What's your hope for the future?
Well, I guess I would hope too that we start having more open-minded physicians. Because when we talk about this issue of sex, what I heard at the beginning of my career and why I got into the issue of sexuality was patients that told me their doctor said sex is dead. And imagine if your doctor says sex is dead to you after a spinal cord injury, you're gonna have strikes against you. And so I think the key is I do think access to care is important. I think the more we can break down barriers is important. And the more we can realize the therapeutic aspects of sexuality are important. I think that, people are very caught up in so many things these days. The world is just so busy, so materialistic, all these kind of things. And if we just get more simple and, maybe instead of watching TV, people have more sex. So there's good things that we can, and you know what? That's also going to be better for the environment. So we have to be careful with these things, and we have to realize that sometimes we kind of have to go back to basics, and I don't think there's anything more basic. So I think on that note, we've left our viewers for a lot of things to think about, and this has been a great conversation.
Yes. Thank you very much to both of you for this interesting conversation. For me, it was very honored to be part of this dialogue. And so thank you very much. And I hope that we will see soon for to go and talk about aspects that we didn't talk today. So stay tuned because we will come back. Thank you very much. Thank you, Dr. Alexander. Thank you, Dr. Sampogna.